All right, Jason. Jason's going to tell us about endovascular interventions.
Great. Good morning. Thanks everybody for getting up early. These are some slides kind of recycled over the years. And so I just made a couple of edits more about personal biases than anything. So I think, I don't have to tell the modern vascular trainee about the advantages of endovascular. I trained at a time when we were right in the transition about 13 years ago, and I can remember going on all vascular fellowship interviews asking, how much endo am I going to get? And I know this current crop comes through basically asking, how much open am I going to get? So clearly there's been a large landscape change in terms of why this current generation goes into this specialty, and certainly we all like the technology and some of the less invasive nature of some of the strategies that we have access to now. And certainly the ability to do these procedures, even aneurysms, but certainly lower extremity things under local anesthesia, without incisions, percutaneous access, outpatient procedures, and short sort of recovery. I think the handful of my trainees in the room know how much I dislike doing leg bypasses, more because early on when I was doing a lot of them with the trainees, I realized the attending position was always standing over the leg, hunched over while the trainee got to sit. And so I've realized that was a bad situation for me, so I've essentially stopped trying to do that. The problem with lower extremity, endovascular, is the further that we get down the leg, the less durable it is. And this is kind of a summary slide from a while back when people were putting together ideas about, open versus endo, and for many years, including in the last decade, you read things about endo first approaches. I always kind of joke now that we really have kind of endo first, second, third, and fourth approach, because we will continue to flog on something to try to keep it open in the leg before subjecting a patient to bypass. And you kind of have to remember in the back of your mind, the bypass is actually a pretty good option for many of these things. Now, certainly the more proximal that you go, and I think so iliac, interventions have pretty much outpaced some sort of aortofemoral bypass just because of the invasiveness of that. But certainly, as you get farther away and you look at where these bars move over, as soon as we start treating femoral popliteal and infrapopliteal segments, everything starts sliding over in terms of 1, 2, 3, 4, and 5 year data. And in fact, as we get down here, there's paucity of long-term data. And that, I think those are the interesting things for those of you that are interested in sort of long-term academic careers. Certainly a lot of headway should and can be made in terms of durability of long-term fem-pop disease. Mark touched upon sort of diagnostic things. I always like to think in terms of philosophically when or why that we need to treat these patients. And certainly claudication, I think, just like Dr. Lumsden mentioned, you're going to see a ton of patients that have some sort of leg pain. And you really have to distinguish the vascular type of pain that they're having and then sort of whether one should be treated. I think we all can think of examples within the neighborhood that we work in and some of the competing specialties or some of the competing offices that are treating 90-year-olds that are nursing home bound just because there's a lesion there. And I think within our specialty, we really want to think about treating the patient and having some improvement in lifestyle. So I always think of treating claudicants as truly lifestyle limiting, and I always even try to engage in a sort of a contract with the patient that if we're going to proceed with treating claudication, they better be either dancing in the streets or running a half marathon next week, because I really think to really change somebody's life, that's the benefit you get from sort of treating claudication. So if it's a little bit easier to push the cart around Costco every weekend, maybe that's not really improving their sort of quality of life. Now, if that's what their whole life is about and they can't push the cart around Costco and you can do that, then but again, it's an individualized decision. I think critical limb ischemia, obviously, because of risk of limb loss, is very important to be sort of aggressive about, and I think anybody with tissue loss should be aggressively revascularized. Now, that being said, there are folks that don't have any more options except something heroic or something really distal or something really invasive. And if they've got a clean-based ulcer and they've got the resources to have a nurse that changes it every day and it's not bothering them that much, or it's being done in the nursing facility and they've got a bad heart or they've got end-stage cancer and they're headed that way anyways, then I think we're treating ourselves and or our pocketbooks if we're being aggressive about those interventions. So again, it's got to be on a functional patient. And then I think one of the more exciting things about things that we do is acute limb ischemia. And there's a lot of nice toys and stuff now that are very different than when I was in training, where we would take a cold leg back and kind of watch radiologists get to do stuff. And I think nowadays, most modern practices and modern training programs, you will be doing that with your, with your faculty and stuff. So the general approach for claudication, conservative management first. They usually have less disease. The disease is more proximal. If you talk about levels of disease, people with critical limb ischemia have multi-level disease. People with claudication generally have one level, meaning ilio, femoral popliteal. Very rarely it's distal. I'm pretty aggressive about sort of inflow disease. I think that balloon expandable stents, covered or bare metal, you can debate that in the literature. Really is a standard of care, I think, for proximal sort of iliacs, raising the bifurcation. One thing that you do have to think about if you get into a routine of being aggressive about proximal common iliac disease is when you raise the bifurcation with sort of kissing iliac stents, that does have some long-term consequence, mainly the sort of inability to flip up and over should they develop future femoral popliteal disease. So think about that when you're treating iliacs, is that you actually make it very inconvenient to treat future lower, much lower extremity disease. And so we see a lot of patients nowadays with femoral popliteal disease that 5-6 years ago got their sort of aortic bifurcation raised. And it just adds a degree of difficulty to doing their SFA intervention if you have to come from the arm. The sort of debate between balloon expandable and self-expanding, that'll be sort of very sort of institution dependent. I think people are interested in the different types of ballooning, many times through sort of comfort with certain types of stents and things like that. I think that hard calcified lesions really need some sort of balloon expandable stent to kind of crack it and hold that. I think these hybrid approaches, this is pretty much really borne out over the last decade. A very common procedure now is femoral endarterectomy, patch angioplasty, profunda, widening, and then through that patch that you've just created, iliac stenting. I mean, I think these are on our schedule basically every week. If not several a week. And I think that's mainly replace aortofemoral bypass. And I think it's a good operation. I think it's durable. The iliac stents are durable. I think a femoral patch angioplasty is very durable. The limitations are you have to have places to clamp, although these days you can use balloon control for proximal and sew a patch in onto almost anything. And I think what's underappreciated is how important the profunda flow is. So I was always taught the profunda was how you kept an aortofemoral open. I think that having excellent profunda flow essentially makes somebody mainly a claudicant, which really from a limb preservation standpoint is probably the most important thing. So for claudicants, really the main goal is to resolve symptoms and not to do something so silly that could convert them to a critical limb ischemia patient. You will get the patient that got treated downtown across the street. They put a covered stent across the common femoral. They didn't understand the profunda was important, and now the profunda's out and the stent occludes. And you'll mutter under your breath that this is why, that we do try to educate even all of the specialties that claim to have some stake in the game here, that they really need to understand the importance of these preserving certain side branch. And I think if somebody has tibial disease and claudication and you're treating it, I think you're under the sort of ethical standards. I think there really should be nobody that has, garden variety claudication with tibial disease. So certainly the outcomes of endovascular for sort of tibial disease, patency-wise, go down significantly over time. But really, the purpose of treating tibial interventions is really for critical limb ischemia. Critical limb ischemia for me is defined as, Rutherford, kind of 4-5 and beyond. So basically, either severe disabling, cannot really move claudication, or rest pain. And this is pretty classic. People will sort of describe at night they have to, dangle their leg over their bed to get sort of relief. It's not the person that is able to kind of walk around and has short distance claudication. I think there's limited durability for these interventions, but again, the goal is to heal a wound or get them out of rest pain to get them out of a limb loss problem. So below the knee strategies generally, somewhat unfortunately in the US, we're limited. Many of you will wind up going to some real nice fancy meetings where we sort of interact a lot with Europeans and people outside US, and they really do have a lot more toys because of the regulatory environment, and you'll certainly see this when we talk about aortic diseases. There really are a lot more access they have to some real fancy things because of the regulatory environment. But these days, I think we are making some headway with drug-eluting ballooning. Drug-eluting stents in the SFA have worked reasonably well. I think a lot of the studies, and this I point you to, reading through the literature, and at your own institution, I think this is a good thing early on in the summer to do a journal club over, because this is a constantly changing landscape. I think in the clinical trials, those are not real world lesions. You got to be careful when you read an industry sponsor, and they're all industry sponsored nowadays, no matter how much disclosure is put in the journal article. I mean, everybody that's involved in these trials has some stake in the game, and that's the nature of these studies. So how do we do these types of procedures? Obviously, Dr. Matos talked about getting a good history and physical and having the right imaging to kind of use it as a roadmap. So I always kind of tell people the reason why we do all these duplex and CTs beforehand is like we would never take a long road trip without playing it out on the map, or at least these days without putting it on the GPS. So same thing when we're about to enter into doing an endovascular intervention. I think antegrade versus retrograde. This is very sort of operator dependent. I don't like antegrade access myself. I think in certain populations or certain pockets of the country where there's a little bit more sort of obesity or where it's harder to get in and make a turn and going up and over, I think the antegrade access can be very helpful, particularly for more distal interventions. I think retrograde, contralateral, meaning if you're treating a left SFA, retrograde right femoral access, I think is the most ergonomic for us, and you have to remember about taking care of us when we do these cases, as well as how the devices are designed and built. So I actually do a lot of brachial access for various things, because I think a lot of people these days have endografts in place, which certainly raises aortic bifurcation, which makes it difficult to treat SFA disease afterwards. I have some biases about brachial access. Probably a lot of you will be doing percutaneous brachial access. I find the complication rate from a brachial puncture is about 30% in our hands. So we have a little cut down tray in our cath lab. We give some local anesthesia, and you make a little cut down so you can put a single stitch in it when you're done. That extra amount of hassle saves you a lot of phone calls afterwards of brachial sheath hematomas and stuff. And then, from a pure sort of financial standpoint, you can bill for a little brachial cut down, which is why we're surgeons, right? We can do cut downs. Crossing lesions, this, certainly spend some time on the simulators today. There's some nice demonstrations of some of the devices that people use for that. A lot of different biases about how to get through things. I actually just like less expensive things generally to do this. So I usually use these CXI Cook catheters along with a stiff glide wire. They have angled ones, they have straight tip ones. There's a lot of real fancy things that the companies will sell you. You can look at them, you can evaluate them. I think, I always try to convince the companies, if you have something free to offer us for a one-time shot at something to do, then take advantage of that. And then, like I said, there's a lot of cool crossing technology. One thing I do use a lot is this reentry outback device. I think that's a very useful thing. I think people 5 or 6 years ago talked about purposely going subintimal, or you'll go to meetings where there's lots of live cases, and some of the Europeans will talk about, oh, look, now we're going subintimal. I think you go subintimal every time. If you really have a lesion that's bulky, I think to convince yourself, like in the diagram, certainly from the paraphernalia that you get from the device companies, this idea that you're right in the center of the plaque, that idea doesn't really exist. I think as soon as you enter into it, you make a loop, you're always going to be subintimal. So I think you need to find strategies to get back in. I think the outback is very good for that. There is some cool technology. There's a company that actually is local in Mountain View, Palo Alto, that was developed by folks that had developed atherectomy, John Simpson, and stuff. And being able to visualize where you are in the plaque, I think, could be useful. You'll see a lot of fancy cases. Like I said, if you go to live cases about retrograde pedal approach, there are catheters and stents and wires specifically designed for this retrograde approach, and I think that's a good tip to learn. I know here a couple of years ago we had a cadaver lab with a model to do retrograde approach. That was like one of the most eye-opening things for me. For even me coming to the boot camp finishing school where we set that up, that I went home and realized, gosh, if I could do it on a cadaver, I definitely could do it on a live patient at home. So that's important if you have a flush SFA or tibial occlusion, you can't see where to go through, or if you failed sort of antegrade. And these days, patients don't like to have multiple trips back and forth, so you got to have that as a backup, kind of ready to go. There's some examples of cases, I think in the interest of time, we'll kind of skip over. So what are really the options, I think, these days? I think just plain old balloon angioplasty is kind of out the window. I think you have concepts of either primary stenting, debulking, and plus or minus drug-eluting balloon or primary drug-eluting balloon. There's a lot of good studies comparing these things. There is some disruptive technology. There's some of the Stanford people developed the shockwave therapy, which is basically lithotripsy for the SFA. We're actually pretty excited about that as an adjunct to sort of debulking. And then drug-eluting ballooning afterwards. So there's a lot of different treatments that'll depend on the place that you're at, and these are kind of all the different options. I would take your time now during training to explore all of those things. Challenge your faculty about the biases that they have. I think these are healthy sort of discussions. Utilize what you did at one hospital when you come back over and rotate at a different hospital to ask about why they have that over the other, and put together in your own mind your own strategy for sort of how to approach these things. So when you're out and practice it, then you've developed your own strategy and skill set. I think they all have their pluses and minuses. Many times we choose many of these things for no good reason except for, well, that's kind of how I was shown how to do it, and I've gotten pretty good results with my patients and my practice and my type of people that I see. So just there's a lot of there's bias and there's science, and I think the science at this point will tell you these are all relatively sort of equivalent. So if you get good at doing something, I'm okay with people saying, well, I'm good at this for the people I see. So I think as long as you can say that to yourself, then I think you're good. So I'll end at that.
So how many of you have done a FemPop? Well, that's good. Fem distal bypass? All right, excellent. So let me start the philosophical talk now that John's kind of walked to the door, kind of feel empowered, and that is that when I trained, we didn't train in any endovascular procedures, and then along came the endovascular revolution, and it was phenomenal for our specialty, and it really empowered vascular surgeon. Now I'm worried about it's going to destroy vascular surgery, and I'm going to quote two conversations that I was in the room for, and one was an advisory board, and a cardiologist was saying, he said, well, there's no point in calling the vascular surgeon. They said, because the new guys don't know how to operate. And Peter Schneider was there, I was there, and they said, these guys can't come out operating the way they used to, so you can't do anything that a cardiologist can't do. And then I happened to be at a cardiac surgery meeting, and completely impromptu, one of the cardiac surgeons was, well, it's a problem if you get an iliac rupture. He said, because young vascular surgeons don't know how to deal with acute bleeding, so we're better off just doing it. So you can see how your competition is going to hammer you if all you can do is use catheters and wires basically going forward. So how do we handle it?
Yeah, I think you really have to go out of your way to within a group, and this is something that we struggle with every day, and we try to keep a nice heterogeneous mix of faculty. I think that's an important part of it, because you do have to have a range of skills, and I think then honestly, folks, one day when you're on the faculty side of things, you have to look yourself in the mirror every day and figure out what your skill set is and what you're good at. I do think the day of the person that did things equally well, I think that's headed towards doomsday. I think there are certain training programs where there is a lot more sort of open surgery, and there are training programs that are heavily weighted towards endovascular. And I think you have to understand the job that you pick, you have to fit into that group so that as a group that you can take care of those patients. I am worried about those kinds of comments. I think the same thing can be said for a lot of the cardiac surgeons that are finishing now. I think that I think there's, say, less and less open thoracoabdominal surgery. So nowadays, everybody's, biting at doing branch stent grafts for that. So one day, the only people that are going to be able to do it are the handful of people that may be trained in Houston or something like that. And, if certain people wind up coming to Houston, that number may sort of diminish over time. So I think that's a moving landscape. But I think that's a fair sort of critique these days about the distal bypass. I think the emergency stuff, I think everybody's still very, very good at doing in terms of basic principles of proximal and distal control, or even getting balloon control, or even stent grafting of, say, like an iliac rupture. I can tell you our guys still call us for every little potential complication that's vascular related. So I haven't seen that switch over that much yet. We don't have that aggressive interventional cardiologists at Stanford. They're so focused on heart failure things. I've never lived in an environment where they've been competing, so I guess my perspective is probably a little different than somebody that might be at an institution where cardiology shares the peripheral vascular space. I can't imagine what that life would be like. I'm sure it would be slightly annoying to me. So.